Welcome to the second 1-hour session of PROSPER, that's proactive reduction of suicide in populations via evidence-based research. So again, we have integrated in the field of contemporary suicidology some of the most important and compelling research studies to help deliver to you the most the sharpest tools, the strategies that we are most confident will help reduce suicides in our population. Here are our learning objectives. Again, these are over the course of all 6 1-hour webinars. They're not to be achieved in any one webinar alone. Just a quick review of last time. Never in US history, Arkansas history, have we seen a steady decrease in suicides. In fact, we've never even seen just steady level of suicides where we've reduced the suicide rate by even 15%. And maintained that rate over time, which means this is still a public health crisis that we do not have our hands around, okay? We do not have operational control over this health variable. In addition, when we look at traditional methods of doing risk assessment, we have these strategies that are sort of like profiling. It gives us this biased perspective as to who we're looking for. But the problem is that there are suicides that happen that are not by white males who are between the ages of 18 and 25 who own a firearm. For example, the group with the fastest growing age cohort who are dying by suicide right now are age 45 to 65. And so if it's not in our profile, we're not going to look for it. We also know that there are 7 of the most common triggers or events that sort of precipitate or precede someone's suicide attempt. And historically, doctors, nurses, psychologists, therapists, counselors, social workers, we're trained to look for those risk factors or those triggers and consider them risk factors. The problem is there are plenty of people who experience these risk factors every day who never attempt suicide. And so even when we look at the broader list of 67 facts that, or characteristics that increase someone's risk for suicide, we can't just take each of those in a checklist format and say, well, if the person in front of me exhibits 1 or more of these characteristics, that puts them at higher risk. It might be statistically true that the person is at higher risk, but using that same rubric time after time with one particular person, that is a within subjects approach, we can't do that. Again, these between subjects research, this is like the research that says the taller you are, the more likely you are to be successful at your career. It doesn't mean I can use height as a hiring rubric, not only because it is discriminatory and illegal, but because it won't accurately give me the most successful employee, okay? Just because something correlates doesn't mean there's a causation there, right? And so we need to be very mindful of this. So the most recent studies we have shown that our ability to predict future suicides is essentially 0. We can't look at, take a profile and apply it to the 100 patients we see in our clinic each day. We can't take a checklist and apply it to every patient who we see who reports some depressive feelings, because it won't predict if they're going to kill themselves or not. So we talked about this last time, and we'll talk about what to do instead later today. But first, one thing that was left over from last time I want to try to cover has to do with language, especially in an increasingly diverse primary care environment. We have more types of providers than we've ever had before. So we might have embedded behavioral health, we might have a pharmacist, we might have a physical therapist, sometimes even an occupational therapist. We may have a psychiatrist embedded, a social worker, a psychologist. So all dietitians, all sorts of different specialties. And if we all use different language, we're going to confuse one another. And we certainly will not be able to accurately communicate about a particular patient at risk. So for example, these words on the screen right now are terms that we would encourage you to take out of your vocabulary. Sadie, a great question in the chat box. What would be better than parasuicide? So we'll get there. You're always a step ahead. I love it. Keep me on my toes. So the reason why we want to take all of these words out of our vocabulary is because they don't really have a basis in research. In other words, we can't say, this is the operational definition of parasuicide. This is exactly what it looks like. And therefore, when people engage in parasuicide, this, or this are the likely, reliable, predictable outcomes. Whereas when it's a suicide gesture, which is operationalized by that, then that's the outcome. We don't have good operational definitions. We don't have good predictors to say that a gesture results in that and parasuicide results in this. These are really just terms we tend to use in consultation with our peers, whether it's just within our treatment team, when we're maybe consulting a specialist like a social worker, a psychiatrist, psychologist. And so they don't tell us anything clinically about what is actually going on and what we should do next. And so because it doesn't tell us those things, we want to use different words instead. Now, the words commit suicide. The word commit suicide, we don't use that because it tends to increase stigma. So we when we talk to people who are struggling with suicide, they will say, well, I didn't feel comfortable sharing with others that I was thinking of committing suicide. And when we ask them further about why, they say, because there are only two things we commit, and they're sins and crimes. And so just even talking about committing suicide makes me feel really unlikely to share, really hesitant to share. And so one of the things that we know from people who have survived suicide attempts and lost survivors, right? So people who have lost a loved one to suicide, when we ask them about what's a better language, they say, just tell it like it is. You died by suicide, ended your life, killed herself, whatever the actual terms are that really describe it, quite frankly. So please do try to avoid using the word commit suicide. When it comes down to cry for help, that's just not a helpful term, because whether someone's crying for help or not, if they're doing the behavior that we're calling a cry for help, isn't it legitimate enough to get our help or to get our attention? In fact, most of these terms, when we think about them, let's say that Jenny and I are consulting on a case, which is magical because I think we just gave her a medical degree without her ever having to pay student loans. So let's call Jenny a psychiatrist for now. She and I are consulting about a mutual patient we have. And I say, well, yeah, our patient John did this. And Jenny says, well, that's just a suicide gesture. And then I respond, yeah, you're right. It's really just a cry for help. What are we accomplishing when we use those terms together while communicating? What's the outcome? What actions are we likely to take next after using those words? You can either unmute your mic or type your answer in the chat box. If I say, what John did was just a suicide gesture, and Jenny says, yeah, it was really just a cry for help. Yeah, Jenny put in the chat box, I think she sent it to me privately, but she said less action, right? So those sorts of comments, actually, it's almost like, yeah, Sadie, great word. It minimizes, it kind of reassures us that the current strategy is good enough. It sort of reinforces the status quo, or says, you know what, there's nothing more that needs to be done here because we're calling this behavior a gesture or a parasuicide or a cry for help. And that's really not helpful, because that's a very social thing. That's got nothing to do with what the research says actually happened, and therefore we actually need to do. So that's why we eliminate these terms. Instead, we use these terms. There aren't equivalents for each of the terms on the last slide, because frankly, some of them are just not useful. They're sort of judgments or value-laden comments and terms. So let's look at the bottom one, suicidal ideation versus non-suicidal morbid ideation. Another word for non-suicidal morbid ideation is non-lethal morbid ideation. A third synonym for this term down here that I prefer because it's less wordy is death ideation. So Suicidal thoughts, death thoughts. These are actually very different. We know that it is very common for people to experience death thoughts. That is the thought that, wow, I wish I were better off dead, or I wish I weren't here. It's a thought that is typically driven from being completely overwhelmed, or having your resources to cope be completely spent. And it really is more common than you'd think. But this doesn't mean I want to kill myself. What this means is I wish I could escape what's happening right now. Once I see myself playing a role in that escape, playing a role in enacting my death, well, now we're talking about suicidal ideation. This one over here is much more indicative of high risk. That is to say that people don't have death ideation and then reliably attempt suicide. People do have suicidal ideation, and reliably we can predict that they may attempt suicide. Sometimes death ideation can grow into suicidal ideation, and in turning into that, then of course they're at higher risk. We should never be hospitalizing someone for death ideation. And trust me, that happens all the time, where a provider hears, uh-oh, you wish you were dead. That means suicide. That means we need to hospitalize you. Not at all. In fact, as we talked about last time, when we hospitalize people prematurely, what do we do to them? They often have a negative experience, and in the future, they're not going to report to us when they're struggling. When we hear thoughts about death or dying, or wanting to, not wanting to live anymore, wishing to be dead, we have to clarify. So is it that you only wish you were dead? Or do you see yourself making that happen, right? And that's how we're differentiating between the first and the second, and therefore what we need to do when someone has death ideation and what they need to do when they have suicidal ideation. Let me hit pause. Any questions about the difference between death ideation and suicidal ideation? We will come back to this next time and do an exercise on it, but for now, let's just stick with sort of the warm-up of introducing the concepts. Okay, hearing no questions, Jenny puts a great comment in the chat box that if we hospitalize prematurely, we may traumatize someone. Absolutely. So now we have two other terms, non-suicidal self-injury and suicide attempt. These pertain to the suicide gesture, parasuicide, cry for help. These are where those come in, okay? So who can pick out the difference between non-suicidal self-injury and a suicide attempt? There's only one distinct difference operationally. What is it? Great job, Sadie. Sadie pointed out intention. That's right. So both things are intentional, but one is done with the thought, either this might kill me. On the softer side, it sounds like, would this kill me? Or maybe this will kill me. Or a little stronger, I hope this kills me. I want this to kill me, right? So in suicidal intent has different gradations. It's not an on-off switch. It's definitely a dimmer switch where people feel different intensities of intent. Now, the thing we have to remember is that intensity of intent, like I really, really, really want to die, versus, oh, I'm sorry, I really, really, really want this to kill me, versus, maybe this will kill me. I guess that'll be fine. Those differences in intensity don't mean anything in terms of what people decide to use to kill themselves. So intent does not correlate to lethality. If someone, I really, really, really want to kill myself, that doesn't mean they use a firearm. Whereas people who say, well, I think I really should try to kill myself, they, I don't know, take pills or hang themselves. That's not how it works. And so intent, we need to consider it as sort of all or nothing, even though it does have gradations. What those translate to in behaviors is very much all or nothing. So in other words, non-zero amount of intent to die. So even this much intent, and what that looks like, again, at the most mild sort of magnitudes or intensities, would be someone who takes, let's say, a handful of Tylenol, and as they're taking this Tylenol, wanting to escape their pain, they question, will this kill me? And they continue to take it. right? Just asking the question, if you even considered, might this kill me? Then we can, and you follow through with that behavior, we would consider that an attempt. Whereas non-suicidal self-injury is something entirely different. These people are not hoping to die. They're not looking to die. So this is like cutting behavior, where we hear sometimes teenagers or sometimes adults who have real difficulties coping will engage in cutting behavior. Sometimes it's branding or burning behavior. And this, when they're doing this, oftentimes they feel numb. And so they're doing this to feel some sensation, whether it's physical or not, it's helpful to them. And then others who feel they're feeling so much emotionally that the physical pain is almost a distractor or like a release for their emotional pain. But in either of these two cases, with emotional pain being relieved by physical pain or numbness being remediated by physical pain, they're not looking to die, okay? And so we don't call it a gesture, we don't call it parasuicidal. They either were thinking, this might kill me, or I want this to kill me, or they weren't thinking about that at all. Everyone clear on this? Really, really important, because especially when we think about someone's medical record, if I'm not documenting this well, whoever that patient sees 10, 20 years from now, they're not going to really understand what actually happened. And if it really was non-suicidal self-injury, but it looks like the way it's documented in the record, like it was an attempt, they're going to assume the worst and probably hospitalize prematurely, which, as you know, creates this cycle of patients going through the system and coming back out not wanting to share with us how they're truly feeling. Similarly, if I'm communicating to my nurse or my nurse, he's communicating to me, I want to know if what he's identified is death ideation versus suicidal ideation. I want to know if what he's identified is, yes, this person really does have a history of 2 or more attempts. It's not just non-suicidal self-injury. He's not just cutting. He was trying to slit his wrists. He was trying to die, right? Okay. So a few other words about cutting or non-suicidal self-injury. We shouldn't just it's good to exhale when we hear that this is happening because it's not suicide. In a way, we as healthcare providers might feel a little relief. At the same time, though, 1 out of 5 people following treatment for this behavior, 1 out of 5 people will repeat the act, and over 20% of those will die by suicide. So it's essentially 10% of people who repeat the act are going to die by suicide. It's unclear if that death is them cutting too deeply and accidentally killing themselves. What we do know is almost half of those who seek medical care following this behavior had consumed alcohol in the period prior. And as we all know, alcohol impairs judgment, it impairs impulse control. So again, non-suicidal self-injury, it's better than suicidal ideation, but it's not as if these folks don't need our help. Okay, they absolutely do. And just a spoiler alert, what they need is coping skills. These are not healthy coping skills. So they certainly don't need hospitalization, but they do need coping skills. Let's talk a little bit about prevalence rates for suicide. If you're in general medical settings, 2 to 5%. We've talked about this already. It's one of the top 10 causes of death among adults. It's actually now number 11. Interestingly enough, COVID comes in at number 4 within the last 12 months, which displaces suicide. So suicide is now number 11. But I think we all know as the vaccines roll out and we get a handle on this pandemic, as we have gotten a handle on measles, mumps, rubella, smallpox, as our vaccination programs get a hold of this and it decreases, we'll see suicide sort of bump back down to the number 10 position for adults. And it's the number 2 cause of death among children. If you do have behavioral health integrated into your clinic, you have care coordination, care management, care navigation, any of these awesome programs where it's being asked more routinely or more frequently, you're going to see a higher prevalence. Now, that's just sort of how it works. The United States Preventative Services Task Force is clear on this. When you ask more about something, you're going to find more of it, right? That's not rocket science. So just be aware that you may see a prevalence rate in your population up to 12%. We know that in the days prior or the weeks prior to a suicide attempt, we'll see an increase in service utilization. So up to 3 visits per month more for suicidal patients. We know they report more physical limitations, lower energy, greater levels of bodily pain. They often report poorer medical care. So, or poor poor health is probably the best word. So I want to be clear, that doesn't mean we should use like 3 visits per month as a profile and start looking in our EHR. Okay, let's derive a list of patients we have who have had more than 3 visits a month recently. That's not helpful, but we just need to keep this on our radar, okay? And what we know is that of those who die by suicide, 45% saw their primary care provider within 30 days of their death. 20% saw their primary care provider within a day of their death, 24 hours. And among the elderly who die by suicide, 73% saw their primary care doc within a month. And so that doesn't mean primary care kills people. No, what we're saying is that it's the ideal window of opportunity to try to catch these folks. Now, some people in primary care will say, well, you know, I have hundreds of diseases to worry about with the way healthcare has become and the amount of reporting and the quality measurement and HEDIS metrics and all of these things around payment. I have to keep track of so much administrative data that it's just not tenable for me to start doing routine primary care screening for suicide. Especially because it's such a low base rate phenomenon. So I can appreciate that. And I can appreciate the physicians and nurses and NPs and PAs who say, you know what, or maybe even the practice managers who say, you know what, we're going to ask as indicated, okay? If someone has anxiety, depression, chronic pain, chronic mental illness, we're going to ask, but otherwise we're not doing it. So here's the problem with that approach. Go ahead and put in the chat box. Can you guess the top 5 chief complaints in these visits before these people died by suicide? So they saw their primary care doc and within a month, some of them within a day, killed themselves. What do you think the top 5 chief complaints were for that last visit before they killed themselves? Go ahead and put your vote in the chat box, put your guess. So Jenny says pain, Sadie says pain. Looks like we have Melissa and Sherry here. T. Waltz, fatigue, okay, great. Loneliness, depression, anxiety, great guess. Anyone else? It looks like we have 2 phone numbers here. You can't enter the chat box if you're on by phone, but you're welcome to unmute and throw out a guess if you'd like. All right, so of the 5 problems, 2 were mental health problems, so anxiety and depression. And then we have GI symptoms, cardiac symptoms, and hypertension. So what this means is if we take an as indicated approach, we're only going to catch 40% of those who are going to leave that appointment and kill themselves. And so we're going to miss the other 60%. Now, my guess is hypertension is in there more so because of a statistical likelihood of having hypertension and visiting the doctor. So it's probably more of a prevalence issue than anything. But again, the take-home message is that when people feel something physically wrong and they're suicidal, they'll still go to the doctor, okay? So just because someone's here for a cold, we can't assume that they're not struggling with a more dire condition like suicidal thoughts. Just talk a little bit about something called fluid vulnerability risk and fluid vulnerability theory. This is no different than someone's risk for cancer, someone's risk for depression, someone's risk for ADHD. We all have a baseline or set point for risk comprised of things like our gender, race, family history, predispositions we can't change, even some biological markers and genetic markers they're finding for suicide. And then we have acute or short-term risk based on situational factors, right? And so maybe my baseline risk is really low and I'm the most resilient person you know, but maybe the acute risk is really high because I don't know, my parents just died of COVID. My house just burned down. My wife just got cancer and my kids got, I don't know, abducted, right? I'm making this up on the fly, but you get the point is that there's a difference between who I come to when I wake up in the morning, who am I as I come to the table versus what's happening during that day, during that week, during that year, that is more of an acute risk. Within primary care, we have multiple different types of people, as I said before, so we have to consider what are our appropriate roles so that we're not tripping over each other, stepping on each other's toes. we published an article in the Journal of Cognitive Behavioral Practice a few years ago. So we encourage you to look that up if you want the nitty gritty. We include a case study in there of a patient to demonstrate how the nurse assisted and played a specific role, the physician did with regard to prescribing, and then the behavioral health consultant played another role. So not going to go through these in depth, but just know that they're out there, and there are suggested practice workflow models to be able to most efficiently and effectively address these patients in primary care. Okay, so let's tap the brakes for a minute and let's do something that's a little more audience participation. I'm gonna ask you a few questions, but we don't want you to answer. We just want you to sort of think about the answer, okay? We come from different walks of life. We have had different experiences with regard to suicidal patients. Some of us have treated thousands of them. Some of us have treated 2 or 3. And so it's important because our life experience, our cultural lens, who we are as individuals, maybe even who we are spiritually, absolutely plays into how we treat suicidal patients who come through our doors. So in an effort to shed some light on our own biases, our own beliefs, and those things that might get in the way of us following evidence-based care, we're going to ask these questions. Again, just think about the answer. This is for your own self-reflection. Why do people kill themselves? Why do people kill themselves? What do I believe morally, spiritually, and/or religiously about suicide? What type of person makes a suicide attempt? Again, just reflect on these and answer them in your own mind to try to understand your own bias, your own beliefs. Can suicide be prevented? Can every suicide be prevented? There's a loaded question. Who do I know who has been suicidal, made an attempt, or actually died by suicide? What do I think about my own personal thoughts of death, dying, and/or suicide? How have the suicide deaths of my patients influenced my own practice habits? And ultimately, what is my responsibility to my suicidal patients as a clinician? So really important to take a look at this. Oftentimes we are bombarded with primary literature and we're told that, well, randomized controlled trials say that this is what we should do about this problem. And inevitably a nurse or doctor says, yeah, that's great that the RCTs say that, but I've had the experience of doing this or doing that. And anecdotally, it's been helpful. So for better or for worse, we absolutely rely on our personal experience as we go forward with any type of medical care that we impart. And we have to consider the extent to which our personal experiences, maybe even a family or friend who we know who's died by suicide, might be playing into our actual practice habits day in and day out, okay? We want to try to mitigate those. Also, the more we have experience with suicide, the more we begin to adopt a role. So our role is not to be a friend, a guardian, a savior, a protector, okay? We cannot save every life. We are putting ourselves at an increased level of self-importance if we really think we can stop every person from killing themselves. If people truly want to do it, they are going to deceive us. They won't tell us what they're truly experiencing. If they sense that we are going to get in their way and we are an obstacle to them working through their suicidal symptoms, they'll just stop talking to us or they won't show. The United States is actually at odds with a lot of the world. The World Health Organization and many other developed nations around the world, they don't have the same duty to warn that we have. We believe that if there's an imminent risk that is foreseeable, we should usurp this patient's autonomy and force them to get help. And in many other countries, that's not accepted. The cultural belief and the mentality is if this person truly wants to end her life, it's her life, that's her decision. And I shouldn't stand in the way of that. And so I'm not suggesting we take that extreme of an approach, but what I am saying is that's more in line with how people feel. So we as a medical system are a bit at odds with them in trying to have a very heavy-handed role or an overly paternalistic role or an overly maternalistic role. If we put on our shoulders that our job is to keep patients alive, we're going to be sad and disappointed and potentially traumatized because it's an impossible goal. Okay, we have to be very realistic with ourselves that our job is to follow the standard of care and deliver the best clinical care that the research says can help. So following the standard of care and the clinical literature, that's our job. Keeping every patient alive is not our job. That is completely unrealistic. In fact, in many cases, when we try to do that, we will transcend professional boundaries. We'll make decisions based on emotions instead of facts or clinical research. A little bit here on standard of care. The standard of care is a legal definition, not a clinical one. So in other words, everything that's gone wrong in clinical care, when it goes through the legal system, then they deem, yep, that's not the standard of care. It should be something else. So when I say our role is to follow the standard of care and the clinical research, standard of care tells us what not to do. It tells us what was inadequate. But like any good teacher, we need to be told what to do instead. And that is what the clinical research tells us. All right. And that's kind of what we're going to continue to cover with Prosper. Okay. So what this means for us is don't do CYA. CYA, I'm just going to excuse my language. It means cover your ass. It means doing things to mitigate your own liability, to protect your own license. If you're following the standard of care, that does protect your license. The only reason a license gets taken away or put on abeyance is because someone hasn't followed the standard of care. So here's the tricky thing. I know this sounds obvious, but many people do this, and I'm here to tell you. If you just focus on CYA, you might be mitigating your own risk, but guess what? You're not doing anything to help the patient. Whereas if you follow the standard of care and the clinical research, you are covering your rear and you're putting your best foot forward to help the patient. So please, 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 you are the only person who can be the honest broker of your own behavior. And this is often documentation behavior, or it's consulting behavior when you've got a patient in front of you and you consult with someone else just to make sure you share the blame, share the risk, spread the risk out. Consult because you're hoping to get more information. Don't consult because you're covering your rear. If you follow the standard of care, follow the clinical research, you are covering your rear and you're giving your patient the best chances of overcoming it. We talked about this a little bit before when we were discussing language. Suicide is not any of these things, okay? Yes, suicide over time, especially if someone's chronically suicidal, maybe if they have a borderline personality, if they have a severe coping deficit, it may, over time, facilitate an attention-seeking pattern. But that attention-seeking pattern didn't start without suicidal thoughts, okay? The suicidal thoughts are distinctly escape-oriented. It is part of the problem-solving repertoire that humans have. It is an attempt to get away from and to stop having to experience emotional or physical pain, or both, or sometimes loss. It's a state of hopelessness, burdensomeness, powerlessness, thwarted belongingness. That's a heck of a tongue twister. Say that one 10 times real fast. Thwarted belongingness is what happens when someone desperately wants to be a part of something, but they're being shut out or kept out. So when we hear that all sorts of special populations have higher suicide risk, so we'll hear like the LGBTQ plus community is at higher risk. We'll hear that adolescents are at higher risk. College kids, sometimes we'll hear that. Sometimes we'll hear about military veterans, right? All of the common denominator between all of these populations is thwarted belongingness, right? Someone who's LGBTQ plus is struggling to come into their own with regard to who they believe they are and who they feel like on the inside. And society outside of them may or may not be supportive of that. They may be exposed to microaggressions or outright aggression. Even racial discrimination and racial aggression. Looking at military veterans, when they come out of the service, life looks different. The outside world does not operate the way the military does on the inside. I'm just speaking as a military veteran myself. And so how they interact with their world, they struggle with belongingness. And teenagers, well, that's obvious. It's sort of that normal developmental process of who am I? Who am I supposed to be? Who are my peers and how am I similar or different to them, right? And we all know that teenagers can be quite mean to each other when it comes to in crowds and out crowds and belonging. At the end of the day, suicide's a state of ambivalence. Most people who are suicidal don't really want to die. They just don't want to live with their pain, but they don't see any other way of getting around their pain other than to live with it. And that's why they think of death. This is really important. It sounds like a word circle, like circuitous reasoning, but think about it for a minute. I have reasons for living and reasons for dying. The only reason I want to die is because life is so miserable. Life is so intolerable. If life became more tolerable, I would never want to die, right? So we only want to die when life becomes unlivable. That's a really important thing to think about. Many healthcare providers have this misunderstanding, and patients do as well, that suicide is a state of indecision. I'm standing at a crossroads, and I don't know if I want to go left and choose life or right and choose death. That's not what it's about. It's about feeling both things simultaneously. And the only reason I'm thinking of wanting to die is because of how horrific or hopeless my life feels. So let that sink in, let that percolate a little bit. It's really instrumental to how we approach patients, because the mere fact that they're sitting in front of you is evidence of their ambivalence. People who are not ambivalent about dying don't show up to our clinic. They're already dead. And it sounds harsh, but it's true. We hear about suicides where the lost survivors will say, we never saw it coming. John was normal at work that day. Or my wife, Sue, she was so normal that day when she came home from work. I didn't expect to find her in the bathtub. Right? So all sorts of signs people leave, it's because they're ambivalent. The folks who are truly not ambivalent, unfortunately, we don't get to treat them typically, okay? They typically go quite quickly and unexpectedly. All right, so let's move to a different topic. Before we started talking at the very beginning today, and this is something we discussed in depth last time, how we can't predict future suicides. We can't line up 1,000 patients who say, I'm thinking of killing myself, and do some analysis to figure out who's going to do it and who's not. But we do have much more proximal indicators that help us understand what to do with this patient from a treatment perspective. So let me repeat that. We can't predict the future. Human behavior is too variable. So we can't predict the future, but we can figure out what's indicated from a clinical perspective when this comes in my door versus that comes in my door. And that's what we're going to talk about today. So this idea of, I'm just not comfortable letting this patient go home, I don't know if they'll do it, try to remove that habit from your mind. That thought process is a future predicting process. The research is crystal clear. We have a zero ability to predict. We certainly can't hospitalize everybody. So what we do have better understanding of is when this walks through my door, here's what the research says works. Whereas when that walks through my door, this is what the research says works, okay? Right on the left side here, we have predispositions and we have triggers. Those are there just so that we understand where the suicidal mode comes from. The suicidal mode is a real thing. This is maybe what you're used to hearing as like active suicidal thoughts or passive suicidal thoughts. We don't really use those terms anymore. What we say is this person's suicidal mode turned on or turned off, okay? And the predispositions and triggers are here because we know they happen, but please, please, please do not use these to try to understand what's about to happen, because these are not good predictors, as the research has said. We've known that these exist for the last 50 years and they haven't helped us curb the suicide rate. So the suicidal mode is characterized by very distinct negative thoughts, feelings, behaviors, and physiological events. So agitation, sleep disturbances, concentration problems, the HPA axis being turned on, so the hypothalamic pituitary adrenal axis being engaged, that releases all the cortisol and the adrenaline and all sorts of biophysiological events that then, of course, make those thoughts even more racing or make the person feel more agitated or more panicked emotionally. It's super important for us to be able to recognize when this is on. Today is Tuesday. If yesterday the clinic got a call from, I don't know, Sue, and Sue said, I'm thinking of killing myself, I need to see the doctor, but I don't get to see her till today at, I don't know, 12:45 Central Time, The first question I want to ask Sue is, are you thinking about it right now? Or did you think about it yesterday when you made the phone call? And if Sue says, well, I thought about it yesterday when I made the phone call, what she's telling me is her suicidal mode is not on. It was on yesterday, which is what prompted her to come into the clinic. So then I might ask, well, it was on yesterday when you made the phone call. How long were you thinking about this? Well, about a minute. Okay. And have you had these thoughts again since making the phone call yesterday? No. Okay. So what I can conclude as a clinician is her suicidal mode turned on yesterday for about a minute. And today, when I see her in clinic, it's off. The reason why that's important is because people will make better decisions when it's off. When the suicidal mode is on, they are so emotionally activated, they're not going to engage in treatment very well. You might even consider doing a mini mental status exam, because we know if someone's mental status is altered, that's grounds for hospitalization alone. So this is very important from a treatment perspective. The other reason why it's so important is because if their suicidal mode is on, our job when they're in front of us is to turn it off. Turning it off decreases risk. If they leave with the same exact amount of risk as they came into the clinic with, we haven't done our job. We should expect nothing to change in their thought process. So how do we turn off the suicidal mode? Before we do that, what I'd like to do is show you a quick video clip of what the suicidal mode looks like. This is a real video of someone. They posted it on YouTube several years ago. They did attempt suicide within about 2 to 3 months of launching of posting this clip. It is 13 minutes long. We're not going to watch the whole thing. And just a heads up, it does have some curse words. The person also does have a slight accent. And so what I would encourage you to do is turn your volume up to max and excuse the harsh language, the foul language. I'm sure it's nothing you haven't heard before, but fair warning is fair. We're only going to watch about the first 5 minutes, okay? Let me go ahead and share this. What I'd like you to do, let's go back for a second. So take a screenshot of this slide, take a picture of it with your phone, jot down on a piece of paper thoughts, feelings, behaviors, and physiology. Just write this as a little diagram. We're going to engage in an active learning activity here, and we're going to watch this video and map out this person's suicidal mode. Once again, write this down, take a screenshot, take a picture with your phone. We're going to map out this person's suicidal mode, their thoughts, feelings, behaviors, and physiology as they all pertain to one another. Okay? All right, here we go.
I hope that this video is somehow helpful. Not actually to me, but the fact I know that I'm only one of millions and millions and millions of people in the world that are just like me, actually. That don't have necessarily the resources that I have in my heart or my purse, for that matter. I was able to escape my country and escape stigma and escape all the things that meant it okay for everybody to use the fact that I suffer from 3 mental illnesses as something to beat me with, rather than as something with which they might, be compassionate. I'm now living in a Travelodge motel in the arse end of New Jersey. I've got a fucking kidney stone. I'm all by myself, and there's absolutely nobody in my life except my doctor, my psychiatrist, the sweetest man on earth, who says I'm his hero. And that's about the only fucking thing keeping me alive at the moment. The fact that I'm his bloody hero. And that's kind of pathetic. And I gave so much love in my life. And I just can't understand how a person can be left so alone. And I want everyone to see what it's like, is why I'm making this video. Then mental illness, it's a bit like drugs. It doesn't give a shit who you are. And equally, what's worse? It's the stigma. It doesn't give a shit who you are. And suddenly, all the people who are supposed to be loving you and taking care of you are treating you like shit. And then when you're angry or you're hurt because they're doing it, it's like a witch hunt. They're pointing at you, going to see, this is why we don't want to do it. And it's like, oh, I'm fighting like all the millions and millions that I know I'm going to stay alive every day, which I'm doing because I love the people that are doing this to me. I'm not staying alive for me. For me, if it was me, I'd be gone straight away back to my mom. Because I've walked this earth alone for 2 years now as punishment for being mentally fucking ill and being angry that nobody would fucking take care of me. Specifically for being suicidal, actually, and for being angry. Everybody's so afraid of an angry woman, and what do I do when I'm angry? I write angry emails. I don't stand screaming, shouting at people. I don't, So all these big hairy men that are supposed to be my family are so scared of the little woman who's sending them angry emails. They're like, that woman has been left. I've been wandering the globe for 2 fucking years. I'm a 5'4" little fucking woman wandering the world for 2 years by myself. Nobody in my fucking life, nobody, except my business manager, who can take any advantage he wanted. You know what I mean? And I'm all by my fucking self, and it's a crime, and it should not be acceptable to any man that knows me and claims to love and care about me, that I'm still sitting here after 2 years and I'm begging to be brought home. Somebody who loves me to come and get me. That's what I keep saying. No answer, never from nobody. Nobody wants me. Why? Because I was angry that they all fucked off. Then they say they didn't fuck off while they're fucking off. Completely invalidating your reality. That's what happens when people think mistakenly or otherwise that you have a mental illness. They use it as something to invalidate every fucking thing you think, do, say, and feel.
Okay. So hopefully you were able to decipher that between the accent, and hopefully you were able to jot some notes down there. Let's go ahead and pull the slide back up. You can unmute your mic if you'd like, or you can put a note in the chat box. Any just impressions real quick? And if not, that's okay. All right. What kinds of thoughts did you hear? Let's start with thoughts. What did Sinead O'Connor say? If you recall, that's the one who did Nothing Compares to You, old 80s tune, written by Prince of all people. What kinds of thoughts did you hear her describe? That she was pathetic. Yeah, lots of self-criticism, that she's pathetic, she's alone, I'm lonely, I'm a burden. Absolutely. That's why I had to get out. I'm fighting. I'm begging. Jenny, that's awesome. She was mistreated and she's stigmatized. Yep. She's angry, felt unloved, has a mental illness. She's even persecuted for having a mental illness, right? Great job, guys. Good. Now, what are the emotions that correspond to all of that? And be careful here. Thoughts and emotions can sometimes seem similar. She was definitely sad. She was crying, maybe distraught, maybe despair, feeling invalidated. Yeah, and that's we could argue that might be more like a thought, but yeah, definitely angry, feeling wronged, which again is more like a thought. She was feeling lonely. We know that, right? Loneliness is an emotion. Feeling rejected. Feeling like no one is willing to help her, feeling unloved maybe, right? Jenny says maybe gaslighted, could be. Yeah, desperate, that's a good word. Yeah, I mean, what did she say? She said, and here's a great, this speaks volumes. She said, they don't love me. I've been asking them to come and get me, but since they haven't come to get me, they don't love me. Do you hear the black and white thinking there? Do you hear the distorted thinking? The thought is, if they love equals coming to rescue me. And since they didn't, they must not love me, and therefore I feel unloved. So you can see how there's sort of a lack of logic and a very idiosyncratic way of defining relationships and experiences in this mode, right? What were the behaviors she was engaging in? This kind of connects with physiology. Anyone notice any behaviors? Yeah, she was withdrawing. Yeah, she was in a hotel room in Jersey. Yeah. So she was withdrawing. Anyone see the skin picking kind of at the beginning, some of the rocking and like the large hand gestures, holding her face, clutching her neck, clutching her chest, right? Those sorts of behaviors that suggest lots of physiological tension. Anyone see the smoke billowing up at the very beginning? Not sure if she's smoking marijuana, smoking, vaping, who knows, cigarettes. So maybe some substance use potentially, who knows? And then what about the physiology? What did you notice physically about her? Shaved head, yeah, yeah. She had a kidney stone, well done. That's awesome, Sadie, well done. Yeah, she had a kidney stone, so she's in some sort of pain. Anyone who's worked kidney stones before, we know that's super painful. She clearly was agitated from a physiological standpoint. Her mood went like this, right? At times she was crying, then a moment later she'd be smiling. So very labile. So that's what the suicidal mode looks like. I'm just typing in the chat box. Is that helpful, unhelpful, or neutral to be able to diagram the suicidal mode by looking at someone who is in that state, whose suicidal mode is turned on? It is not true that most people who kill themselves are in that vegetative, super depressed state. In fact, most people in that state don't even have the energy or concentration to kill themselves. It is much more likely that you'll see this very agitated, not thinking clearly, not really processing well. Okay. All right. So really important to look for the suicidal mode. As we said before, our goal is to turn it off if the person's in front of us. If they're not in front of us, that's fine. But we need to know that if they're in clinic, their suicidal mode is turned on, we want to turn it off. And we don't do that by talking them out of it. We'll get to that in a minute. These are some of the things that suicidal patients will often conclude about themselves. And it's really important to disabuse them of any of these, all of these. If you hear any of these things come from their lips, we've got to jump on it. The reason why is if they, for example, if they continue to believe I'm not who I thought I was, then they'll engage in behaviors that are uncharacteristic of them. If they feel like they're losing control and they start to believe it, they will lose control. So these sorts of beliefs that are frankly not accurate and not helpful, they can set up these self-fulfilled prophecies. So instead of these, when you hear these come out of their mouths, you have to instead help them understand that suicide is a state of ambivalence. It's not that you're losing control. It's not that you're going crazy. It's that life has become so intolerable that you're actually considering killing yourself. And so you're ambivalent about these two things. It is so helpful when patients hear that, because ambivalence is a place of power. And it's a place of power because I have a choice, right? But indecisiveness is a place of feeling like you're backed into a corner, like you have to choose one thing or the other, right? So really tapping into that ambivalence and explaining it to them, educating them, just like we would educate them about anything else in primary care, is just so important. It helps us avoid these sorts of interactions where this is how the patient feels. So as you're reading this, you can bet that the way the patient felt was that the doctor was probably going through a checklist and said, well, are you going to kill yourself again? Why? Because the doctor didn't know how else to address this problem. As I said in our first webinar last week, our goal in Prosper is to teach you how to fish, not to just give you a fish. The doctor in this example only had a fish, did not know how to think about suicide, how to talk about suicide, and how to understand suicide. And that's where we need to do better as a medical community, okay? There are several ways we can be more collaborative. In the first webinar, we talked about developing mutual trust. We have to consider that the patient is the expert of their own problems. We can't have this I'm on high, I'm the doctor approach. We have longitudinal research that says if we ask patients on a scale of 1 to 5, if 5 is very likely and 1 is very unlikely, how likely are you to kill yourself? Patients who answer a 4 or 5, if we follow them over time, many of them do kill themselves or attempt. If they answer a 1 or 2, they don't attempt. So it is perfectly valid and reliable from a scientific and clinical approach to
write that 5-point Likert scale out there from 1 to 5. 5 is very likely, 1 is very unlikely. How likely are you to kill yourself? Now, obviously, if they answer a 3, there's somewhere in between, we haven't really gained much information. The 3, however, might just suggest their ambivalence, okay, which is what we know. When we're communicating to them, we have to make sure these messages come across, if not explicitly, implicitly. Any patient I'm seeing who's an adult, I always tell them at the beginning, look, I know we're about to talk about something difficult, and I know that you can kill yourself if you want, and you can just not share with me. My goal is not to get in your way. My goal is to help you help yourself. And if you are forthcoming with me, then I'm able to do that. Now, I don't say that with kids, by the way, because they are subject to more suggestibility. And if I say, I know you can kill yourself, they might take it as sort of an encouragement. So just a footnote on that when working with kids and adolescents. So we're going to wrap up here and we'll get into this next time. Let me skip to the resources that I usually give. Just want to share these, the books. And again, you'll get these slides after. Any questions I can answer. Really appreciate your time and participation today. Any questions I can answer? Don't all speak at once. If there are no questions, that's okay. We can just meet up next week again. But if there are any, feel free to shoot now or shoot me an email. All right, Jenny, I think we have our answer.
Well, all right. Well, thank you, Dr. Corso. Thank you, everyone, for showing up. Next week, same time, same place, same Zoom link, and I will send a reminder out. If you haven't taken the pre-test, let me put a link in the chat. I know we've gotten into it, but would you still like them to take that, Dr. Corso?
No, I'm so glad you asked. If you haven't taken it at this point, we've given you half the answers.
Okay. Never mind then. All right.
Thank you. Take care.
Thank you, Dr. Corso. Thanks, everyone.